Hey, thank you so much for tuning in to learn about the Epic Intraoperative Anesthesia Handoff tool. The goal of this tool is to help you give a complete handoff with key information provided at your fingertips, and to ensure that when you receive a handoff, you feel like you have a complete understanding of the case that you're about to take over. The Epic Handoff tool is designed as a checklist or a conversation guide. So we will show 3 short scenarios of clinicians using the handoff tool in a variety of surgical cases, as well as in a variety of ways. Our first case will show the use of the tool in a relatively simple case, where 2 clinicians are handing off at the patient's bedside, using the tool as a script to actively guide their conversation. Our second case shows the tool in a more complex case, again with clinicians handing off at the bedside and using the tool as a script. And then finally, our third case is going to show the use of the tool in a simple case done by supervising physicians who are handing off in the office and using the tool as a checklist to really double check the completeness of the handoff that they just finished. We hope that from these videos, you can get a feel for how to use the handoff tool to adapt to the case, the patient, and your particular handoff style and needs. Thanks for watching.
Hey, how's it going? Hey, good. What's up? I'm on call tonight, so I'll be taking your room.
Awesome.
You mind going over the case with me?
Absolutely. Yeah. Let's take a look.
So, yeah, the patient's a 35-year-old female, past history significant for obesity. Everything's going great. Induction was really smooth. Nothing too exciting going on. She had a 20-gauge IV placed preoperatively. I went ahead and put another 18-gauge in because her arms are tucked.
Oh, perfect.
So, yeah, probably about 20 minutes left. Nothing really special planned as far as pain management. But let's go ahead and pull up the handoff tool, take a closer look. So, let's see. Yeah, normal mask, McGrath 3, grade 1 view, 7.0 ET2. She's still paralyzed with rock. It looks like the resident just gave her another dose. She got Decadron, still needs Zofran. Has had a liter of fluid in, and we don't have a Foley. So yeah, that's really, I don't really have any concerns. So just excavate and go to PACU.
Awesome. Yeah, sounds pretty straightforward.
I'll go ahead and sign in and perfect. Send you on your way.
Sweet.
All right. Thank you. Hey, how's it going?
Oh, hi.
Hey, I'm here to relieve you. You ready to hand off?
Oh, fantastic. Yes, I am absolutely ready to get out of here.
Awesome.
Let me tell you about this patient.
Please.
Good. Let me open up our handoff tool.
All right.
Good. So let me just open up his pre-op note. He's a little bit complicated.
Sure.
So this is a 56-year-old gentleman. He has a history of hypertension and COPD. Both are very well controlled. Pre-op labs looked fine. But he's here for a craniotomy for tumor.
Okay.
Resection. So we've been going for a while at this point. He got no pre-procedure meds. From an airway perspective, he was an easy mask. He was a max 3 grade 1 view. He's got an 8.0 tube in. He's doing well, ventilating well.
Perfect.
Lines-wise, he's got the 20 gauge from pre-op. I placed a 16 as well. So you have good peripheral access, so I didn't place a central line. You've got a right radial arterial line there too. Meds-wise, so standard induction meds. You got some propofol. You did get rocuronium, which we then reversed with sugammadex after we were positioned and lined up.
Yeah.
And that's for neuromonitoring. So he's also running a propofol drip in addition to some SIVO.
Okay.
Neuromeds-wise, he got Keppra, and we did 10 of Decadron. Okay. The surgeons don't think they need mannitol. They said they'd ask for it if they want it.
True.
They're under the microscope now, and they look like they're doing fine. So I think you're good.
Sweet.
Yeah. And then otherwise, little bits of phenylephrine here and there. Nothing too exciting, except for antibiotics.
Perfect.
Yeah. Eyes and nose wise, so he's probably at an EBL of about 300 or so at this point. Nothing too crazy. Yeah. We're like 1.5 liters in of crystalloid. We've got about 2 liters of urine output. So everything looks pretty okay.
Good.
Eyes and nose wise. You do have some RBCs. They're on hold in blood bank.
Okay.
I didn't bother getting him in the room.
Yeah, no worries.
Yeah, and the attending knows that they're not in the room. We don't think we'll need them. Yeah. Great. So let's talk about some situational awareness.
Yeah.
Anticipating any changes, not at this point. We're doing MEPs and SSCPs for monitoring, and those signals all have looked really good. We haven't needed to do anything about those. We don't have any particular map targets or anything. They're under the microscope and doing well, so I think you're in a good spot.
Good.
Nothing needs to happen right now. In terms of labs, nothing is pending. We just sent the baseline ABG this morning. It was normal. I think it taped on the machine. You can take a look later.
Sweet.
Yeah, you could send one in another hour or so if you want.
Sure.
Yeah. I don't have any particular concerns. The surgeons haven't been complaining about anything. I think you're good.
Good.
So post-op plan is to extubate. The mental side is like neuro intact.
Yeah.
So nothing to worry about there. I think he can get extubated. He does have an ICU bed.
Okay, cool.
Yeah. Analgesic plan, little bits of fentanyl, just, don't burn your bridge.
Yep.
Need neurotex on wake up.
Yeah.
Polyme plan, the Decadron was up front. There's some Zofran back there for you, if you need, for when you need it, I suppose.
Yeah. Yeah.
Yeah. What questions do you have? What can I tell you?
No, that's perfect. I guess only question I had is how much longer do you think we have on the case?
Good question. I would guess maybe another 2 or so hours. It's been a pretty delicate dissection.
Okay, cool.
Back there. Yes, it's great. I will sign out and sign you in, and Dr. Smith is your attendee. So yeah, follow her with anything. I'll let her know that I'm heading out.
Okay, cool. Sounds good.
Thanks.
All right, see ya.
Hey, how's it going?
Oh, hey.
You ready to get out of here?
Yes, I am.
All right, let's talk about it.
Fantastic. Yeah, let me just open up the handoff tool here. This is a kind of complex patient, so I'm just going to open up the pre-op note. So 64 years old. She has hypercalcemia, hence we're here for a pyrothyroidectomy. Okay. She has end-stage renal disease. She's on HD. She got it yesterday. Labs this morning looked good. Her K was 4.3. Her hemoglobin is 8.2, but that's pretty much her baseline, so we weren't too worried. Otherwise, normal labs. She also has diabetes, and she's on a GLP-1 agonist. Like, no nausea or anything, but she took it, I think, like 4 days ago. Okay. Just so you know. Good. So pre-op wise, she got nothing from us. Airway wise, we did an RSI, so we did not try to mask her, just because of the GLP-1. We have a NIMS tube in, 6.0. It was easy to place with the McGrath 3. Electrodes are in good position. Perfect. She has just the PIV from pre-op. It's working well. Arms are tucked, but it's working fine. Okay. Meds-wise, pretty standard induction meds. Propofol. We did do sucks for induction instead of rock. We're monitoring the recurrent laryngeal. Oh, sure. Hence also the NIMS tube. This all makes sense. Great. So no long-acting anything for her. Otherwise, let me see, little bits of fentanyl. She's needed a couple pushes of phenylephrine, but we haven't started a drip or anything like that. So she's doing well. I's and O's, we're at 250 of crystalloidin. Okay. My attending just wanted to minimize that because she's anuric, so she obviously doesn't have a Foley. And her EVL's, I mean, it's like 5 if even at this point. So next to nothing there. Otherwise, key events, I just wrote down when they started recurrent laryngeal nerve monitoring. So again, no long-acting paralytics for her. Signals are all good on that. Yeah. Okay. So for situational awareness, we're not anticipating any changes or problems. Nothing needs to happen right now for her. There are no labs pending. I have no particular concerns. My plan is just to extubate and get her off to PACU afterwards. Analgesics-wise, we'll do, again, little bits of fentanyl as needed. What questions do you have?
I think sounds pretty straightforward. Kind of complex patient, but pretty easy procedure, sounds like.
Yeah.
Are we going to have to run PTH? Or?
Oh, good question. Right now, the sample is off at frozen, so as long as they get a good read from pathology, we won't need PTH levels. Okay. But if you do, you have access to repeat if you need them. Okay. Yeah. Good. Anything else?
No, I think that's it. Enjoy your time at home.
Fantastic. Thank you. I'll see you later.